It's my pleasure to welcome you tonight and to thank you for joining us this evening for an important conversation on cancer, COVID, and the Co-Immunity Project. At Gilda's Club, we believe that while living with cancer is not a choice, how you live with it is. Living with cancer with joy, with style, with purpose, meaning, and even with laughter. That's what Gilda's Club is all about. We offer a supportive community and a variety of programming to assist families living with cancer, both during their treatment and beyond, because life is meant to be lived, even when cancer is a part of it. Unfortunately, this pandemic has caused unprecedented and wide-sweeping issues for the entire world, issues that have been especially profound for families living with cancer, families who are already facing a difficult diagnosis and facing higher risk from a COVID infection. And of course, many of those families are facing increased isolation, additional stress, fear, and anxiety, the symptoms that we treat at Gilda's Club. Families living with cancer need us now more than ever, and through more than 100 virtual program offerings, telesupport, and lots of home deliveries, we're helping to ensure no one faces cancer alone, especially now. We believe strongly that community, collaboration, and science are important sources of hope and even joy for cancer patients and their families. And tonight is an opportunity to learn more about those efforts and research taking place and what the future holds for our community and beyond. It is my honor to introduce a nationally renowned researcher, an oncologist, and just an all-around great guy, Dr. Jason Chesney, director of the Brown Cancer Center. Jason?
Thank you, Karen. And I'm really excited to be here tonight, and I'm really excited to say that the work that Gilda's Club is doing is really complementing the life-saving research that's happening at the Brown Cancer Center, and we're excited to be partnering with you tonight. I want to thank everybody, Gilda's Club, the Kentucky Cancer Program, everyone who's joining us tonight. This is creating a partnership and demonstrating a shared commitment to the community and to all of the cancer patients in our communities. I'm really excited about the presentations of the work that's going to be shown tonight, particularly from Paula Bates and Rebecca Redmond and Kenneth Palmer. This shows the dedication of our researchers, our oncologists, our healthcare partners at the University of Louisville towards not only curing cancer, but also making sure our most vulnerable population does well through this pandemic. We're committed at the Brown Cancer Center to serving our cancer patients, not just in the clinic, but by advancing our understanding of cancer in the lab. And we think that bringing those two together, the clinical care and the cancer research, will save lives. Not tomorrow, not in 50 years, but today. And so it's very important for us to be part of this this evening, and this effort. Many cancer patients are at higher risk of not only being infected with the virus that causes COVID-19, that's SARS-CoV-2, but they're also at risk of suffering from severe respiratory complications from the virus. And the Brown Cancer Center, a lot of people don't know this, but back in February, before all the hospitals shut down, before universal masks were put into place, when people were still talking about it, we decided to very quickly institute infectious disease precautions. And by that I mean masks, checkpoints, distancing in the facility, wiping down everything. That caused a little bit of, there was a little bit of controversy around that, but we decided it was important because we knew, based on the science, that cancer patients would be at greater risk of getting the virus and possibly dying from the virus. And I'm proud to say today that we've not recorded a single transmission of the virus at our facility. We've had several patients come in who were infected. We've had several staff and doctors who got infected outside of the facility, but none have transmitted the virus in the facility. And it demonstrates how important masks are and distancing in these very basic measures. But we don't think that's enough. I mean, 200,000 people have died of this virus this year in the United States. And so we simultaneously with the precautions, we initiated investigations into the virus, how the virus gets into cells. And you'll hear from Paula Bates, who has a drug that can block how the virus gets into cells. And we believe that this focus on our cancer patients, on preventing the transmission of the virus at our facility, allowed us to be able to treat patients at the normal rate that we treat them. We had patients coming from across the country, frankly, from other facilities that had closed down so they could get care here. So we believe we save lives by doing this. We believe that our research is saving lives. We believe that we have a moral obligation to the community, not just the entire community, but in particular to the vulnerable cancer patients during this pandemic. Tonight, we're fortunate to have university partners. The Center for Predictive Medicine for Biodefense and Emerging Infectious Diseases is here tonight. The Christy Lee Brown Envirome Institute is here tonight. Several members of the Brown Cancer Center are here tonight to talk about the impact of COVID-2, not just on the general population, but in particular on the cancer population. This evening, we're joined by leaders in all these institutions. First, you'll hear from Dr. Rebecca Redmond, who's the Brown Cancer Center's Deputy Director of Clinical Research. She's an Associate Professor of Medicine, a practicing medical oncologist, and she'll share her insights from the actual clinic. After that, we'll hear from Paula Bates, Professor of Medicine. She's the co-director of the Kinetic grant, which is an NIH Reach hub for commercialization of new ideas. She's a fellow in the National Academy of Inventors and a co-leader of experimental therapeutics and diagnostics at the University of Louisville and the Brown Cancer Center. She's going to share some updates on research surrounding COVID and some new cancer technologies. And then last, you'll hear from Dr. Kenneth Palmer. He's the director of the Center for Predictive Medicine for Biodefense and Emerging Infectious Diseases. And he's a co-investigator for the Co-Immunity Project. You've probably heard about this in the Courier Journal and on all the TV stations. Kenneth has been at the forefront. He's run a lab that has been testing for this virus in healthcare workers and in the general population from the very beginning, before the state was doing it, before the city was doing it, and frankly, before the federal government was doing it. During our Q&A session, we'll also be joined by Kenneth's partner, his co-investigator, Dr. Aruni Bhatnagar. Dr. Bhatnagar is the director of the Christina Lee Brown Envirome Institute, and he's the principal investigator for the Co-Immunity Project. So right now, it's my pleasure to turn over the evening to Dr. Rebecca Redmond. Again, she's an associate professor and deputy director of clinical research, and she's actually an endowed professor in clinical trials research, the George A. Bush Jr. Professor in Clinical Trials Cancer Research. She is running our head and neck program, is a major international figure in gastrointestinal cancers, and has a unique understanding of the impact of COVID-2 on cancer patients. She's published widely in her field and is a highly regarded colleague and friend of mine. Dr. Redmond?
Thanks, Dr. Chesney. And thanks to Gilda's Club and the Kentucky Cancer Program for inviting me to be a part of this evening's presentation. You know, I had a patient who once told me that with cancer, she has come to expect the unexpected. And I would say 2020 has been unexpected to say the least. You know, cancer patients and survivors and those of us who care for them know unexpected, right? That is our lives. And so what do when you find something unexpected? You gather information, you make a plan, and then you adjust those plans again and again and again. When we first started hearing reports out of Wuhan in March, there was information coming out that cancer patients were about twice as likely to be infected with COVID, and the incidence of COVID in cancer patients was twice that of of others in the city without cancer. And in fact, patients with cancer were also more likely to die of COVID-related complications. So for those of us in the cancer world, as we saw that unfolding, not only in China, but also in other parts of our country, it really prompted us to put in place procedures to try to protect our patients and our staff as quickly as possible. So as Dr. Chesney mentioned, kind of universal masking is something we adopted very early, screening checkpoints, and then also telemedicine. So we jumped on the telehealth bandwagon as quickly as we could to try to minimize exposure risk for our patients. To me, telehealth calls never were a substitute and really never are a substitute for an in-person exam. But to me, it was a way to triage visits in a way. For example, if a patient wasn't doing well, you know, perhaps we made that decision together for them to come in for an in-person evaluation. However, on the other hand, if someone was doing well and didn't report any new alarming signs or symptoms, we might decide to push that off another 3 or 6 months. I have to share a true story. Is my very first telehealth visit was with a patient of mine who works in construction, and I dialed in, and I see his wife's face pop up, and she tells me that, oh, he's out on the roof trying to finish up a project, but she's going to go get him. And so I thought, okay. So she proceeds to carry her phone with my face on it outside and point it up at the roof and try to call him down and say that I need to talk with him, to which he responds, well, I can talk to her from up here. And she said, no, she needs to see your face, at which point he said, well, I guess I can come down. And I thought, well, this is probably someone who's doing okay. It's probably okay for him to wait a few months to come see me. And I felt a little unsafe with him being on the roof, so decided to kind of cut that call a little bit short. But on the other hand, there were patients who had new concerns and noticed a new lump, or I could just see across the video that they had lost weight. And we kind of made the decision that despite any potential risk there could be for them coming in, that it was worth an in-person evaluation. There were many patients that opted to continue their treatment. Our doors were open that whole time. There were others who decided to wait and reassess the situation in a few months. And we tried to guide patients in those decisions as best we could with the information that we had at the time. Nationally, many clinical trials for cancer were put on hold, not only at industry sponsor level, but also at various institutions. We at the University of Louisville did have a institution-wide hold on research in an effort to minimize risk to both employees, staff, and then patients in clinical trials. However, there was a mechanism by which physicians and investigators could apply for an exemption to that for clinical trials that were providing potentially life-saving treatments, because we all know cancer can't wait. Cancer is not going to wait for COVID. And so there were patients where we didn't feel it was appropriate to put their treatment on hold. So much was unknown in those early days, and so much of what we do in oncology is based on sort of assessment of risks and benefits. And so that was difficult when we didn't really know what the risks were, and really still don't. Potential risks to cancer patients, can include immune suppression from chemotherapy, so perhaps they could have more disease related to their immune suppression. The opposite side of that is those on immunotherapy. Immune checkpoint inhibitors could potentially have hyperimmune responses, where their immune responses go haywire when exposed to the virus and create a lot of inflammation and severe disease that way. And so we really weren't sure what risks our patients were facing. As you all know, New York was one of the hardest hit states in the early days of the pandemic, in the US at least. And they early this summer published a report in a Nature journal describing they had 423, I believe, patients diagnosed at their cancer center in a 1-month period between March 7th and April 10th, somewhere around there. And of those 423 patients, they looked at those who developed severe disease. And it turned out that those patients who were on immunotherapy and immune checkpoint inhibitors had about a 2 to 3-fold increased risk of having severe COVID-related disease and ending up in a hospital. The other risk factor identified was those over the age of 65. Interestingly, having had major surgery or even chemotherapy in the 30 days preceding their COVID diagnosis did not seem to increase their risk of severe disease. But again, that sort of put all of us on edge a bit and made us cognizant of the fact that our patients may actually be at greater risk of complications, and felt an even greater duty then to protect them. Another study looked just at cancer patients, so about 2,000 cancer patients at about 65 institutions across the United States, and found that cancer patients in general represented about 1 out of 20, so about 5% of the cases identified. But represented about 1 out of 13 deaths. So you can see that cancer patients, again, were more likely to have severe related disease and perhaps even die of COVID-related complications. So that, again, was concerning to all of us who care for cancer patients. Interestingly, when they looked at trying to figure out what those risk factors were, the risk factors that came out were really those that we associate with risk of severe COVID infections in non-cancer populations. So greater age, multiple other medical problems, male gender, actually. But interestingly enough, again, the type of cancer that they had, or the type of cancer that they had been, the type of chemotherapy or treatment or surgery that they had had, didn't really seem to impact their risk of severe disease. So that started to give us some idea that, there is some risk there, but perhaps that risk can be mitigated. Perhaps it's still safe to start getting people back in the door. Finally, there was one more study that actually looked at cancer patients in general, and really looked at proximity to their last treatment. And again, found that those who had received treatment 4 weeks prior to their diagnosis versus those who had not received treatment in that preceding 4 weeks really did about the same. There didn't seem to be an increased risk. So again, a little bit more reassurance to those of us caring for these patients that we needed to get them back in and get patients back on treatments, and cancer doesn't wait. I think what it will probably take years to uncover is in the early days of COVID, in the interest of conserving PPE and minimizing risk to patients, there were a lot of elective procedures, including cancer screening, including cancer surgeries, that were delayed. And what the impact of that will be on cancer incident rates and even death rates down the road, I think, is yet to be determined. But I think what is so important is that we learn from this information, so that if we were ever faced with a situation where there needs to be widespread quarantine, again, that we have that information to be able to make better calculations about risk and benefit. The other thing that was really important and exciting to see is the work that has come out of a lot of our researchers at the university with respect to treating COVID, and interestingly, the overlap between cancer treatment and COVID. And so Dr. Paula Bates is going to be up next, and she'll tell you a little bit about that. Dr. Bates is a professor of medicine and as Jason mentioned, co-leader of the Experimental Therapeutics and Diagnostics program. She's widely published. Her research focuses on DNA aptamers, which are small segments of DNA that bind to a specific target. And in particular, her group has done quite a bit of work on an agent called AS1411, a true bench-to-bedside study looking at it in cancer, and was really the first anti-cancer aptamer to be tested in clinical trials, and is now a big part of her current research efforts in COVID. Dr. Bates?
Thank you, Rebecca. It's very interesting to hear how much we've learned about the interactions between cancer and COVID-19 and what this new virus means for cancer patients. I have a few slides to show you just to illustrate the types of things I want to talk about today. And I'm going to focus on trying to tell you why this longtime researcher from the Brown Cancer Center has recently found herself becoming a COVID-19 researcher as well. And so if I can have the next slide, I wanted to start by just talking very briefly in general about why cancer researchers are studying COVID-19. And the most obvious thing, of course, is that this virus is making life very difficult for everybody, but especially for cancer patients. You heard from Dr. Redman and Dr. Chesney about how cancer patients may be more susceptible to catching the virus or developing COVID-19, and especially the severe life-threatening version of COVID-19. And some of the challenges, additional challenges that COVID-19 is creating for patients who had cancer in terms of receiving their treatment and keeping themselves safe. Dr. Redmond's told you that in many cases we know a little bit now about how cancer therapies might affect the susceptibility to COVID-19, and for the most part it seems fairly good news in that there is a little bit of increased risk, but not so much with things like chemotherapy and surgery. One thing that still is a little uncertain, especially for some therapies that target the immune system. So we know that very many of our cancer patients, up to 40% of cancer patients these days, are eligible to receive these immunotherapies, which modulate the immune system and kind of wake it up from the effects of cancer, which is trying to hide from the immune system. And there's a lot we don't understand about this very complicated interaction, even just between cancer and the immune system. But now also we have to worry about this additional interaction with this new virus and how that interacts with both the effects of the cancer and the effects of cancer treatments. But on the next slide, I'm showing there's some very interesting parallels between cancer and viruses. It may not seem obvious, but there are several ways in which this SARS-CoV-2, the virus that causes COVID-19, is like a cancer in some ways. And one of the big areas of overlap is how the immune system responds to both of these things. The immune system can detect a virus because it's foreign, but it can also detect precancerous cells and cancer cells because they, in many cases, look different from healthy cells. When the immune system works properly, it actually protects us from getting cancer and also from getting COVID-19. But we know that, unfortunately for us, both the virus that causes COVID-19 and cancer cells have ways to avoid being detected and destroyed by the immune system. And especially in the case of COVID-19, sometimes the reaction of the immune system can be too much. It can cause some of the problems that we see. So we see some of these side effects with cancer immunotherapies occasionally, that the immune system becomes overactive and does damage. And in the case of COVID-19, we know that the virus itself not only causes damage to the body, but the immune response to the virus can cause some of the worst problems associated with COVID-19. And so in both cases, we know that there are ways that we can treat COVID or treat cancer by modulating and changing the immune response, trying to unmask the cancer or the virus in some cases, or trying to calm down the immune system when it goes into overdrive. The other way in which these two things are connected is the fact that we may have therapeutics that are able to target both of these things. We know that there are some molecules on the surface of human cells that may play a role in both virus and cancer. So rather than having to start from scratch and finding new drugs to treat COVID-19, we might try to repurpose some of the drugs that we already know are safe in humans that we've been tested or use in cancer to treat COVID-19. And perhaps what's most important of all that I wanted to share with you today is that studying COVID-19 and especially the immune response to the virus that causes it can really ultimately help us to find better ways to treat cancer. I've explained some of the parallels between the two and how the important role that the immune system plays. And I guess it's significant to me that the immune therapies that we use today arose from research that was done several years ago, not specifically to find cancer drugs, but just in trying to understand how the immune system works. And so I think that the research that we do trying to understand how the immune system responds to the COVID-19 virus may ultimately lead to better ways to modulate the immune system to treat cancer. And so on the next slide, I want to switch gears a little bit and talk about my personal story, how I became a COVID-19 researcher or a fledgling COVID-19 researcher. And so this started back at the very beginning of this year when I first heard about this new coronavirus, and probably like many of us, started to worry about it and wonder if there was something I could do to help in some way. And so I hatched an idea about a possible way to treat or prevent SARS-CoV-2 infection based on some research that I'd done in cancer related to a protein which is called nucleolin. And so on the next slide, I wanted to just show you a little bit about nucleolin and how it's different in cancer cells and normal cells. So nucleolin is not a terribly exciting protein. It's actually what we call a housekeeping protein. It makes protein in the center of a cell in a place called the nucleus and the nucleolus. And in a normal cell, it just gets about its business making protein when the cell is dividing. But it's also a stress response protein. And so when cells get stressed in any which way, nucleolin moves out of the center of the cell into this cytoplasm surrounding it and ultimately to the surface of the cell. And that presence of nucleolin on the cell surface helps the cells to survive the stress. And cancer cells just love to kind of hijack any mechanisms that normal cells use to protect themselves and survive challenges. And so cancer cells have very high levels of nucleolin on the cell surface all the time. And so on the next slide, you'll see that we figured out a way to take advantage of this as a way to treat cancer. And so actually many years ago now, me and my colleagues, Donald Miller and John Trent, discovered a molecule which we called AS1411. And this molecule is known as a nucleolin aptamer. It's a piece of synthetic DNA that we make chemically. And the important things to know about it is that it binds very specifically to nucleolin protein. And because synthetic DNA can't get to the inside of cells, when it's floating around the body, this molecule AS1411 can only see the cancer cells. It can only see them because they have nucleolin on the surface, whereas the normal cells don't. And so we can use this approach to specifically target and kill cancer cells. The other important thing to know about this protein is that we've tested it already in clinical trials. We treated over 100 cancer patients, and what is important about that is that the drug appears to be very safe. We did not see any serious side effects as a result of that drug in over 100 patients that it was tested in. And so the next thing I want to talk about is the role of nucleolin and viruses. So this very kind of initially boring protein turns out to be even more interesting because not only does it play a role in cancer, if I can have the next slide, I'll show you that it plays a role also in viruses. And so back in January or February, I had no idea whether it might play a role in the SARS-CoV-2, the new coronavirus, but I did know that nucleolin played a role in a lot of other different viruses, including some of these highlighted here that are other types of coronavirus. And so we know that in cases where cells are infected with virus, they get stressed. And so nucleolin moves to the surface of the cell. And in at least some cases of viruses, we know that nucleolin can help the virus get into the cell, move to where it needs to be in the cell, and therefore replicate itself and spread and spread the virus to other cells. And so I came up with this idea of perhaps the nucleolin aptamer AS1411 can block SARS-CoV-2, the new coronavirus infection. And so on the next slide, you'll see my kind of stroke of luck is that I happen to be at the University of Louisville. Had I been elsewhere, it may have stopped at the idea stage. But I'm not sure if everybody here is aware, what great facilities we have here at the University of Louisville, not only for cancer research and cancer treatment, but also for these emerging viruses. It just so happens that I know Dr. Kenneth Palmer, who is the head of the Center for Predictive Medicine, which is one of only 14 labs in the country that can really do these high safety level extensive research with the new coronavirus. And so I approached Kenneth and I told him my crazy idea. Unfortunately for me, he agreed to look into it. And so on the next slide, I didn't want to spend a lot of time showing you data. It tends to bore a lot of non-scientists, but I just wanted to show you this. This was the very first moment that we got an inkling that perhaps we were onto something and that AS1411 might prevent infection or block infection by the novel coronavirus. And so what you see on the left here, that pink square is a dish of cells. It's a dish of cells that are quite happy and healthy and growing and covering the plate. What you see in the middle is what happens to those cells when you add the SARS-CoV-2 coronavirus to them. You'll see that there are far fewer cells. They are clumped together, and those of us who spend our days looking through the microscope at cells will tell you that those are not happy cells. They are sick and dying cells. And what you see on the right here is what happens if you take those cells and add AS1411 as you infect them with the new coronavirus. And I'm very grateful here to Kenneth Palmer and all those names of his colleagues there that you see at the bottom who were able to do this really nice research which showed us we might be on to something. And so in my last slide, I just wanted to just give you a very brief update of where we are with this research and where we plan to go in the next few months. We know that we have this experimental drug. We expect, based on the clinical trials that we've done in the past in cancer, that it will be a safe drug and can move quickly to human clinical trials. Dr. Palmer and his colleagues have done a lot of new experiments. They've repeated those experiments I've showed you. They've taken human lung tissue cells and human nasal tissue cells and shown that they're able to, the AS1411 is able to block infection in those systems. And we are very grateful to the support that we've had that has made this research possible. The University of Louisville supported the early research, and as a result of a kind gift from UPS, we were able to complete those experiments that I've talked about today. And moving forward, we're working with a company out in California called Qualigen Therapeutics, and working with them, we expect to be able to do those things that we need to do to scale up the manufacture of the drug, get authorization from the FDA to go into human clinical trials. And we're very hopeful that we can begin human clinical trials to try and treat and prevent COVID-19 in patients as early as the beginning of next year. And so with that, I will thank you, and be very happy to answer any questions you may have about the research that we're doing. And then it's my great pleasure to be able to introduce Dr. Palmer, who is the person who has made this all possible and is responsible for this cancer researcher becoming a COVID-19 researcher. I have to look at my cheat sheet over here. Dr. Palmer, of course, I know, is the director of the Center for Predictive Medicine for Biodefense and Emerging Infectious Diseases. He holds the Helmsley Charitable Trust Endowed Chair in Plant-Based Pharmaceutical Research. He's a professor of pharmacology and toxicology and a co-investigator on the Co-Immunity Project. And Dr. Palmer's own primary research is in developing vaccines and antivirals that address pathogen diversity and counteract immune evasion strategies. His group's developing broad spectrum antiviral strategies for prevention and treatment of emerging and re-emerging viral infections, including highly pathogenic influenza and coronavirus. And with that, I'll hand over to Dr. Palmer.
Thank you very much, Dr. Bates, for the kind introduction and for the collaboration. It really has been an honor to collaborate with Dr. Bates and to collaborate with Dr. Bhatnagar and their colleagues. Infectious diseases, of course, affects everybody. And it's ironic that the pandemic has really helped us forge strong and collaborative research links across different disciplines at the University of Louisville. I would like the next slide, please. So, as Dr. Bates mentioned, the University of Louisville has the distinction of having one of the 14 regional and national biocontainment laboratories. And our biocontainment laboratory is located on the Shelby campus of Hurstbourne and Shelbyville Road. And we here have the Regional Biocontainment Laboratory, which is a LEED Gold facility that includes BSL-2 and BSL-3 containment laboratories. We're a member of the NIAID, NIH National and Regional Biocontainment Network, which includes the 2 national labs, one in Boston and one in Galveston in Texas, and 12 of the regional biocontainment labs. At the Center for Predictive Medicine, we offer preclinical infectious disease research services to both to U of L colleagues and faculty, as well as to industrial partners and anybody who would like to work with us using our very unique biocontainment facilities. We are, as is described in our name, approved to work with tier 1 select agent pathogens. These are pathogens that the government has identified as particular bio-warfare threats, but also with emerging and neglected and rare infectious diseases. Some of the models of infectious disease that we work with at the Regional Biocontainment Lab include influenza, including highly pathogenic avian influenza, encephalitis causing arboviruses, and very topically, coronaviruses that cause severe disease in humans, including SARS coronavirus 2 that emerged in 2003, Middle Eastern respiratory syndrome coronavirus, or MERS coronavirus, which continues to infect people in the Middle East, and SARS coronavirus 2, which of course we're all living. We also work with Yersinia pestis, plague, Burkholderia pseudomallei, which causes the melioidosis. Both of those organisms have been previously weaponized. And we also do work in multiple drug-resistant bacterial infections. The Center for Predictive Medicine provides, as I said, preclinical services for evaluation of vaccines, antibiotics, and antivirals. And so when the SARS coronavirus 2 pandemic emerged outside China back in February, we were very well placed with the experience and the facilities to start doing research on this problem, and also to help fill the gap that existed early on in providing diagnostic services in Jefferson County and Louisville. Next slide, please. So back in February, the National Biocontainment Lab, Regional Biocontainment Lab Network proposed to all of our members that we should offer SARS coronavirus 2 diagnostic services. And very quickly, my colleague, Dr. Donghoon Chung, established and validated a real-time quantitative PCR assay to test for active virus infection. We have to date conducted more than 15,000 PCR tests for SARS coronavirus 2, and I believe made a real impact in Louisville in the earliest part of the pandemic, when we were one of the only laboratories conducting testing. My colleague, Dr. Crystal Komorski, then established and validated antibody assays, serology assays, to measure antibodies against SARS coronavirus 2. And this allowed us to test for historical virus infection and to also assess the immune responses that people had to the virus infection. Then our colleagues, Dr. Chung and Dr. Zhou, who's a member of the Brown Cancer Center, and Jennifer DeMarco, established assays to measure whether functional virus neutralization, whether antibodies had function in neutralizing virus infection in human blood. So this was a test to see whether antibodies can stop virus infection. We also established a new clinical and infectious disease diagnostic laboratory called the University of Louisville CPM Emerging Infectious Disease Lab. And this was only made possible by very generous philanthropy from the Jewish Heritage Fund for Excellence. Next slide, please. Establishing all of the diagnostic capabilities at the Center for Predictive Medicine allowed us to develop interactions with Dr. Irini Bhatnagar and his team at the Christina Lee Brown Environment Institute. And this is a nice example of where the technologies that we had developed for detecting the virus interacted very well with the Environment Institute's interest in community health. The Environment Institute has a very distinguished research history in looking at cardiovascular, the impacts of the environment on cardiovascular disease, and Dr. Bhatnagar and his colleagues are really world leaders in looking at community health. And so the interaction with Dr. Bhatnagar and his team and leaders in the Louisville healthcare community led to the establishment of a project called the Co-Immunity Project. And as the the name of the project suggests, we're looking in the community for evidence of immunity to the coronavirus, SARS coronavirus 2 that causes COVID-19. The co-immunity project has grown into a multifaceted study looking at the impact of the virus on the community in Louisville and on the environment. And the first part of the co-immunity project was assessing how the coronavirus infection was impacting the frontline healthcare workers in our co-immunity healthcare worker study. And that was to identify risks to hospital frontline healthcare workers and patients, and understand really what the incidence of infection was in that group of people. And we assumed right early on that the frontline healthcare workers would be the most susceptible population to infection, because they would be the people that were interacting with COVID patients. And so it was important to understand how many of those people were infected and what kind of antibodies they were producing to the infection. The environmental aspect of the project is really led by the Environment Institute, but they're looking at the whole environment impact of coronavirus, looking at its presence in wastewater and in surface water, and then another human study where they're looking at a randomized sampling of the population in Jefferson County and Louisville to see how many people are actually infected and what kind of immune responses those people are mounting to the infection. As we all know, the incidence of SARS coronavirus 2 is underestimated, because there are a large number of people who developed asymptomatic or mildly symptomatic disease. And so, although those people would still be a risk for community transmission. So it's very important to understand both the number of sick infected coronavirus infected people in the community, as well as the number of people who are only mildly or unaffected by the disease. Next slide, please. So just to summarize what the Center for Predictive Medicine side of the co-immunity project has achieved, we have performed approximately 2,000 PCR tests for virus infection and antibody production in the healthcare worker study. We've done 2 rounds of testing essentially the same community of healthcare workers. We've conducted approximately 4,800 tests for virus infection and antibodies in the community. And we found that the overall infection rate is higher than the known infection rate reported by the city and state. And this is unsurprising and shows that Louisville has very similar experience with the COVID-19 pandemic than many other cities in the United States. Of course, as I said, the overall infection rate is higher because of asymptomatic and mildly symptomatic people who haven't had a diagnosis that we're able to identify in the random screening. Dr. Rini Bhatnagar is the overall principal investigator on the co-immunity project, and I'm sure will be very happy to discuss the population data further when he's given an opportunity to talk. On the next slide, I just give you a little bit of data to show what we're doing in looking at the immune responses to SARS coronavirus 2. On the left-hand side, you see a cartoon that shows the SARS coronavirus 2 structure. The virus is called a coronavirus because it has a sort of a crown of spikes on the surface of the virus. And that protein, the spike protein, is the primary site where antibodies can neutralize the virus infection. So all of the vaccines that have been developed focus on vaccinating people with spike proteins so that they develop neutralizing antibodies. But the virus also has other structural proteins in its capsid, and the main one of that is the nucleocapsid, which does not mediate virus neutralization, but still is immunogenic. So we have been looking in the blood donations from the volunteers in the co-immunity project for antibodies against the spike and different kinds of antibodies, immunoglobulin G and mucosal antibodies, and early IgM antibodies that come up soon after infection. And we've shown that the tests that Dr. Homorsky and her team have developed are very effective at distinguishing between people who have not been infected prior versus people who have a historical infection. We've also been looking at antibodies, the quality of the antibodies, the functionality of the antibodies in preventing the viral infection of cells. And we have found that nearly everybody who has been infected with SARS coronavirus 2 produces antibodies that neutralize the virus infection, which indicates some level of hope that people who have been infected with the virus should generally be protected from reinfection, at least in the short term. I'd like the next slide, please, just to acknowledge all of the people who have contributed to the co-immunity project research, in particular Dr. Rachel Keith and her team, who have coordinated all of this human subjects research, viral infection screening by Dr. Chung and Amanda Lasnik and Dr. John Klein and their diagnostic team, antibody screening by Dr. Crystal Homorsky and her team, functional screening by Jennifer DeMarco and Jung-Ho Cho, and of course project coordination by Dr. Bhatnagar and Dr. Keith and their team. This project has benefited greatly from Louisville community philanthropy, and we are extremely grateful to the Jewish Heritage Fund for Excellence, the James Graham Brown Foundation, the Owsley Brown Family Foundation, several anonymous donors who've provided extremely generous gifts, as well as to the University of Louisville President, Dr. Bendapudi, and the Executive Vice President for Research and Innovation, Dr. Kevin Gardner, who recognized the importance of this pandemic on the Louisville community and provided immeasurable support for us getting this program up and running so that we could provide a positive impact on the Louisville community. Thank you very much for the opportunity to present, and I'd be happy to answer any questions if there's time.
Hello, everyone, and good evening. I'm Elia Fox. I'm the Executive Director of Development for the University of Louisville Health Brown Cancer Center, and I'm going to be moderating our question and answer discussion this evening. As a reminder, if you have any questions for our panelists, please type them into the Q&A feature, and we have quite a few questions that have been coming in already through the chat and were sent in through registration. So to begin, I'm going to direct this to Dr. Bhatnagar. Are there any preliminary findings from the co-immunity project that you can share with us this evening?
Yes, Alia, sure. If we can go to slides, and we're not going to show all of them, but maybe go to slide number 6. So we, as Dr. Palmer mentioned, we did 2 sets of studies, which is with the healthcare workers and then the community study. And in the healthcare workers, we did one in June and one in August. And we found that at least 1% of the participants who were our healthcare workers within the University of Louisville tested positive for the virus, and about double that for the antibodies. So we think that the rates of infections are very low in the community, at least within our healthcare workers, and the type of precautions, particularly the use of the PPE and sort of social distancing, have been very helpful in preventing this spread of infection within the community. And so we did over 1,000 workers the first time, or 1,300, and then we did another 1,000 in the last month, and we will keep doing it. The question that's popped up, how long we'll continue. Well, we intend to continue as long as the pandemic is with us. I think this is an important way of looking at what is happening in the community and what is happening within the hospitals. And I don't think there is any reason that we should relent even after the pandemic is over, because we have to monitor continuously for any outbreaks that may happen. Then, as Dr. Palmer mentioned, we also did a sort of a random sampling of the community, and this is important because you may have heard that people go and measure that some people get tested and then they get some X amount of positivity rate, but all that is very subjective. The positive rate you get is how many people come forth and get tested, and then we don't get the people from different parts of the city and perhaps even the most vulnerable people. So what we found was that one way to do this was to invite people to come to our study. So in June, we sent out about sort of 20,000 letters of invitation, and last month we sent out 30,000 letters of invitation, and we got about 4,000 people to respond. So collectively, from this work, we found that maybe there are about 15 to 20,000 people that have been infected in Jefferson County, and we have only reported about 4,000 to 7,000 people at the time that we were doing the study. So it means that we are missing a lot of people. The second important thing we found was that most of the rates of infection, which is double than anywhere else in Louisville, was in the West End. And particularly among our Black participants, we found that the infection rates were so much higher. Not only that, the fatality rate, once you get infected, the risk of dying was so much higher in the Black populations that we think that requires additional insight, additional focus. So we will sort of reporting our latest round of results on Tuesday from the mayor's office, and then we will do another set of studies in November and in December, and then we see how the pandemic goes and how often we need to do. So we will continue doing this, or the only thing that we might vary would be the actual sort of different times in which you do it, how far apart we do it.
Thank you, Dr. Bhatnagar. Another question for our panelists. If you have active cancer but have elected not to do chemotherapy or radiation, would you be considered at higher risk than the general population? I am 60 years old and my cancer is in my thymus gland and lungs. Thanks in advance.
So Leah, I'm happy to take that one. So from the data that's come out so far, we don't think so. Most of the studies that have looked at cancer patients, at least across the United States, have suggested that most of the risk factors that predict an increased risk of COVID infection or severity of infection really are the same risk factors that the general population faces. So for example, over the age of 65, those patients with multiple other medical problems in addition to cancer, those are the patients at greatest risk of infection and then severe infection. So just having cancer alone may not actually be an increased risk for COVID.
Thank you, Dr. Reckman. Another question, do you expect that COVID-19 clinical trials or vaccine trials will be offered in this area? With the clear higher risk to individuals with cancer, does the Cancer Center leadership anticipate encouraging individuals seeking treatment there to take part in vaccine trials, take vaccinations as soon as it's available? Dr. Redmond, I think I'll direct this one to you as well.
Yeah, no, I'm happy to. So I think much of that will depend on, clinical trials have very tight, specific, what we call inclusion and exclusion criteria, which really seek to maintain safety of a clinical trial. And so, sometimes patients with cancers or other medical problems may not be eligible for some of the cancer or some of the vaccine trials. However, if they are, I'm always an advocate of enrollment in clinical trials. For most vaccines that we give for other cancers, for other infectious diseases, so flu, for example, are safe to give in cancer patients. There's no increased risk to cancer patients from getting a flu shot, for example, and in fact, we think it helps protect them from influenza. And so in general, vaccines are safe in most cancer patients. Of course, that's dependent on the therapy and the type of cancer, and you should always discuss that with your doctor before getting any vaccines. But I don't see having cancer alone as a reason not to participate in vaccine trials if that's available.
Thank you, Dr. Redmond. I have several now for Dr. Bhatnagar again. Are African American cancer patients more susceptible to COVID-19 due to higher immune inflammatory response?
So we don't have any specific data for that. We don't know whether there is cancer-specific increase in susceptibility of individual patients. We just know that overall there is a higher sensitivity.
Another question for you. Can you tell us how long it'll take to get the surface water results? And also if wastewater epidemiology is being used in Louisville for any other purposes, e.g. tracking opioid use?
Right, so we started using wastewater epidemiology even before the pandemic started, and our sort of interest that time was to look at drug use and nicotine, tobacco use in different communities. Unfortunately, that got stalled because we had COVID, but we are fortunate that we have pre and sort of in mid-COVID data. So we are doing these studies as we speak. We have done at least 5 or 6 rounds. We are measuring in 15 different locations in the city. We're doing twice a week and taking out samples, wastewater samples, and looking for the virus in those samples. I think the CPM again is a very critical partner in doing all that work. And what we have found was that we see a progression of the virus through different wastewater basins, which allows us to track how much the virus is progressing in the community, but more importantly, to find out areas where there are large or higher rates of the virus. And again, not surprisingly, the highest rates that we find are in the West End, that we have more viral load in the wastewater there than we had in the east or southern Jefferson County.
Thank you. 2 more questions for you, Dr. Redmond. In clinical remission with ovarian cancer, and last chemo session was end of July 2020 and surgery on April 20. How cautious do I need to be going out of my house?
You know, from the data we have, just as cautious as the rest of us, to be honest. You know, again, for patients who have either had major surgery or even recent chemotherapy, there may be slightly increased risk, but not significantly so, at least over those of us without cancer. And so I would say as cautious as the rest of us, you know, wearing masks, washing your hands, staying away from large crowds are important steps. But I think with being cautious, you can kind of slowly sort of get out into the real world, so to speak, because isolation is a real thing, you know, especially for all of us, to be honest, who have, you know, dealt with social distancing and quarantine now for 6 months, but particularly those patients with cancer and other medical conditions who have had to be extra cautious. That's a real thing. So understanding the need to kind of go back out into the real world, so to speak, but being cautious.
And in addition to that, Dr. Redmond, at what stage post-diagnosis with COVID-19 would patients be treated?
At what stage post-diagnosis? I'm not sure I understand the question. Can you repeat it again?
Gladly. It reads, at what stage post-diagnosis with COVID-19 would patients be treated?
Got it. Post-COVID diagnosis. Got it. So that is an evolving topic, to be honest. Is it at a point where you haven't had symptoms for so many days? Is it at a point where people should be retested and shown to be negative? That even the health department sort of guidance on that is changing weekly, if not daily. In general, the thought currently is that for patients whose symptoms have resolved completely, they are back to sort of their baseline selves for at least 14 days. That has generally been our recommendation, is that it's 14 days have elapsed since the last symptoms.
And Dr. Bhatnagar, another one for you. If people produce antibodies, How do you account for reoccurrence in sane patients?
So maybe Dr. Palmer can sort of add to that, but what my view is that it is very difficult or very rare that people get, once they get an antibody response, that they can get infected again. As Kenneth showed in his data, there is a wide range of antibody response, and some people have very high levels of antibodies, which are very strong in the sense they're neutralizing, and such people may be expected to have higher levels of immunity than those who have low antibody response, and that might diminish over time. So that's sort of my understanding. I'm sure Dr. Palmer, who has done much more work in this area, would know better. So Kenneth, I'm pointing to you.
Sure. I think that there are very few documented cases so far of people who have recovered from COVID-19 becoming reinfected. So we believe that the immune response is protective. There is this phenomenon of people testing positive multiple times after they have recovered from the infection. And we believe that that just reflects people shedding virus RNA, but not still being infected in the longer term. It's a kind of a quirk of the PCR diagnostic. It's a very good way of identifying people who are infected, but it's extremely sensitive assay. And so some people have the virus RNA that persists there longer than the virus infection itself does. So that's my best answer at the moment. This is a really evolving field, and we're getting new data all the time.
I think there, I agree with Kenneth. There may be some of these infections that are kind of false positives in terms of the RNA, and there are a handful of cases of documented reinfection. But when you think that they've been 33 million infections, and we know, just about a handful right now that where it's really clear, because it's a different strain of virus, that reinfection has occurred, that in the very vast majority of cases that there will be some degree of protection after having been infected with the virus. But I think what we don't know is how long that protection is going to last. So, I would encourage people, even if they've been infected, to still keep wearing that mask and keeping distance and taking those precautions.
So I would just add that we don't know the general experience so far, but we can speak from what we have learned, and what we have learned, and this is work that Kenneth did, was that in the healthcare workers, when we found people had antibodies, and if we retested them, I think 3 or 4 months later, the antibody response was preserved in most cases. And there may be slight diminution in the strength of the antibodies, but by and large, there was not a drastic difference. So, I mean, this is only a 4-month-old phenomenon, so we don't know, but we'll see what happens in the future.
Thank you. I have another question for you, Dr. Bates. And with everyone's permission, we're 8 minutes over, but we have several more questions that have come in, quite a few more questions. So I hope that this is okay with our panelists to continue the conversation. Dr. Bates, if you're able to move to the clinical trial stage in early 2021, how quickly might you be able to move your vaccine, which we would believe to be a very safe option, to the place it's commercially available?
Yeah, thank you. Thanks for that question. So just to clarify, our approach is not a vaccine, it is actually a treatment. So it would be used in people who had been infected, and the hope would be that somebody with a mild infection or a moderate infection, we would treat them and prevent them from becoming much more serious, and hopefully prevent severe disease. At the same time, I'm sure there are many many vaccines, being developed, and some of those are in quite late stages. They're in phase 3 clinical trials now. And so there's a prospect that we will have a vaccine become approved within the next few months, and it will be several months after that before it becomes widely available. And so our feeling is, this might be kind of happening in parallel. but there will probably be a need for treatments in addition to a vaccine. Of course, we don't know yet if a vaccine is going to work, but even if it does, it'll take some time for it to be distributed, and there will be some people who won't be able to take it. There will be some people who choose not to take it, maybe, hopefully not, but and so there will be a need for treatments, just as we have a seasonal influenza vaccine, and yet people still get the flu. People still need treatments with antivirals, and so that's where we see our treatment fitting, is as a kind of complement to these vaccine development programs.
This is a multi-part question. Has there been a drop in the average number of people being diagnosed with cancer because of the fear of going to physician offices? Have patients decided to hold off on treatment because of that fear? And a kind of follow-up, I think, question as well to you, Dr. Redmond, specifically, are there certain types of appointments that are important to have in person instead of virtually?
Yeah, I mean, I think that, so to kind of go first to screening, so as you may know, for a period of approximately 3 months, many cancer screenings were put on hold. So many, generally speaking, mammograms were not being done, colonoscopies were not being done. And that was really in an effort to conserve PPE at a time when there was a lot of uncertainty. And so without a doubt, there was a slight decrease in diagnoses of cancers for a short period of time. Most of those facilities have reopened, and so we expect that we should kind of catch back up to where we were. As far as cancer patients choosing treatment versus not treatment, most patients, I will say in my experience at least, and at our cancer center, most patients chose to continue treatment. Again, we very early on sort of adopted universal masking and screening checkpoints and things like that, and most people felt that the risk to them from their cancer was greater at the time than the risk from COVID. And so most patients chose to continue treatment. There were some who chose not to after discussion, and we just chose to kind of reevaluate in 3 months. And I would say that at least in my own experience, almost all of my patients have resumed treatment at this point. But that was certainly a personal decision. You know, there were patients, again, with those risk factors, those patients who are older with a lot of other medical problems, particularly those with chronic lung disease who are on home oxygen, who felt that they were at very high risk, and I would agree, such that they really, really kind of socially isolated and didn't even come to their doctor's appointments. I'm sorry, was there another part I didn't address?
No, that answered it. And to follow up to that, as COVID precautions are becoming more commonplace, are you starting to see more people engage in cancer prevention actions like HPV vaccination and routine cancer screening?
Yeah, definitely routine cancer screening again, as facilities reopen and are starting to do more cancer screening again. Primary care doctor offices are back open. I hope the same would follow with routine vaccinations as well. I don't know that I have data to support that, but I would assume that that's the case now that people are returning to their doctor's offices and kind of getting back on schedule.
And a question that came in is whether the Brown Cancer Center will be joining the National Consortium of Cancer Centers addressing the impact of COVID and cancer, or will be working independently. I also texted this question to the Cancer Center director, who explained that since we aren't in an epicenter, our membership in some of that consortium is very limited, but I'll also see if the panelists would like to add to that.
I can speak really briefly to our involvement, at least in a clinical standpoint. A lot of the National Cancer Institute working groups and cooperative groups have sort of banded together to form a prospective study where when cancer patients are diagnosed with COVID, with their permission, we follow their course and try to determine what factors impact how well they do. So we are in a part of that study and engaging in that from a clinical standpoint.
And this is the last question of the night, and it is directed to both Dr. Bhatnagar, Palmer, and Bates. The question is what the community can do to support you.
So certainly from our point of view, if we really do ask the community to participate in our monitoring and surveillance. It does provide us very useful information. We are in touch with the mayor's office and the Metro Health on a weekly basis. We meet for an hour. We show them our results, the community testing, wastewater testing. So all of that is very critical for us to be able to grapple with this pandemic in all its forms, socially and as well as scientifically. This is very, and we completely rely on the generosity of our participants to participate in this. And it's free, but it still is an effort to come and join us. So that's will be the biggest ask of all of this.
Dr. Bates, Dr. Palmer, is there anything that the community can do to support your efforts?
We've been, I would just echo Dr. Bhatnagar's call for people to participate in our research studies. That's a very valuable asset for our research programs. And the University of Louisville benefits a great deal from a very supportive community in Louisville and Jefferson County. And I would ask that the community continues to support the University of Louisville in our research and teaching missions. And thank everybody for their support and their help.
So I would just want to add one more point, Ilya, is that one of the reasons for doing the healthcare worker studies was to find out what the level of infections was in the hospital. And we found it was very, very low, much lower than the community. So I think that one of the things that we want to reiterate is that it is that we want to assure the public and community that the hospital is safe places to go, and that the likelihood of getting infection is very low, whether it's the cancer center or the general UofL hospital. And more importantly, and we've seen this for cancer, we've seen this for heart disease, people don't show up and then they develop more serious and grave complications that require more attention and have more adverse effects. So I want to reassure that the hospitals are safe and there should be sort of no hesitation in seeking medical care as it's involved, as required.
And I just echo what both Kenneth and Aruni said. You know, we feel very fortunate to have these great facilities, but mostly to have a community that supports research in all ways by attending events like this and by giving to support our research that we're doing to move these things forward. We're very grateful for everybody in attendance tonight.
Well, there have been several people sending thank you messages to all of the panelists for your time tonight and a very informative and important conversation. Thank you all for staying on with us and all of the great questions and conversations running over. So to close out the evening, it's my honor to turn it over to Dr. Aruni Bhatnagar. Dr. Bhatnagar is a professor of medicine and distinguished university scholar at the University of Louisville. He is the director of the Christina Lee Brown Environmental Institute and co-director of the American Heart Association Tobacco Regulation Center. Dr. Bhatnagar?
Well, I just want to thank everyone for being here, for participating, and for actually giving us an audience and in a sort of an opportunity to present our research. As you know, as you've seen, that we do a whole range of work, which ranges from cell biology to actual cell animal studies, but also human studies and also community involvement. So I think that the whole spectrum of research is being possible not only because of the exceptional colleagues that we have here, but also support from the James Graham Brown Foundation, from the Jewish Heritage Fund for Excellence, from the Osley Brown Family Foundation, and many, many other anonymous donors who've sort of helped us in our work and to do this critical work. And I just want to add a personal note in that when we needed this to be done quickly and urgently, when we had no federal support and we had no resources to do all of this, the community stepped forward within weeks to offer resources, and offer support, and offer guidance and participation to do this. And so I think we are like the governor says, we are the team Kentucky, but we are together here to work all of this together so that we could do the best, or make the best we can from this what is really a horrible situation.
Thank you, everyone. Have a wonderful evening. And thank you again to Gilda's Club of Kentuckiana for being our host this evening and offering this great collaboration. And thank you to the Kentucky Cancer Programs and the Brown Cancer Center for coming together. Have a great night. Thank you.
Thank you. Good night.
Good night.
Thank you all.